Okay, everyone, welcome. It's exciting for me um, to introduce Andre Davila, who's going to be our featured lecturer today. So I just want to do a quick introduction of Andre, and then we'll move forward with his presentation. So Andre did his internship at the University Hospital, Federal University in Santa Catarina, medical school at the same Federal University of Santa Catarina, and residency at the General Hospital Medical School at the University of Sao Paulo. He did also another residency at the University of Sao Paulo. He did a fellowship at the OLV Hospital with Pedro Brigada, and graduate medical school at the University of Sao Paulo. He then joined the faculty at INCOR, which is the premier academic institution in Brazil and probably all of South America. So I first met Andre in 2001 when I traveled to Brazil to learn this new technique called pericardial access, and it was insane. I remember all of the buzz about it because these crazy Brazilians somehow were able to access the pericardium, even in the absence of a pericardial effusion. And actually, many prominent EPs went to Brazil. I'm not calling myself a prominent EP. I wasn't. Somehow they accepted me to come down there and spend a week with them. For those of you that don't know, and actually, this is what I wanted to share, this picture. This is a picture. Andre, I don't know if you remember this. I don't know if you can see it yet. So yeah, that's what we used to look like.
Exactly.
This on the far right is the late, great Eduardo Sosa. So Eduardo, Andre, and Mauricio Scanavaca, who's not pictured here, were the ones who actually came up with this concept of pericardial access in the absence of pericardial effusion. And that's when I first met Andre. I was learning about this. We became friends, and then I don't remember exactly how it happened, but somehow we're able to entreat him to come to Mass General. Now, initially, he was only able to do preclinical work because of regulatory reasons, but eventually we were able to make it so that he could also do clinical work, which was really fantastic. After that, he actually introduced me to a lot of things. He was actually the first one to introduce appendage closure to me, because one of the very early versions of Plato was actually tested at INCOR in Sao Paulo, and that's what got me interested in appendage closure, and I'm still a little interested in that. He and I were actually the ones that came up with the idea of doing the VT symposium. I remember we were on a plane to go to Prague, or maybe on the way back, and we came up with the idea of doing the VT symposium, and I think came up with the very first the first program, and along obviously with our colleagues in Penn, that's been going on now for a number of years. And I guess the other big impact he had on me was he helped me sort of make the decision to leave Mass General, and we went together along with Srini to First University of Miami, an ill-fated decision, and then to Sinai, and it was great. And then Andre made the arguably disastrous decision to leave Sinai. But I guess he's done pretty well. He's now the director of the Cardiac Arrhythmia Institute at the Beth Israel Deaconess Medical Center and the Harvard Thorndike Electrophysiology Institute. He also, unconventional as he is, maintains a part-time appointment as a consulting electrophysiologist at the Hospital Cardiológico Florianópolis in Brazil. And if you saw pictures of Florianópolis, you'd understand why he maintains that appointment. He's pioneered and has been interested in really all aspects of electrophysiology, catheter ablation devices. He's authored over 250 original scientific articles and numerous book chapters, and most recently has edited a book on epicardial catheter ablation. So, but most interestingly today, we didn't ask him to talk about epicardial access. We asked him to talk about his approach to substrate modification and scar-related ventricular tachycardia, and particularly his recent work on doing the procedure potentially without even VT induction. So I think with that, Andre, please. I think everyone's very excited to hear you talk.
Thank you, Vivek. I'm gonna try to share my presentation here. Do you see it?
Yeah, we see the presenter view, so you got to switch it. Okay, perfect.
Okay, thank you, Vivek. It's always a pleasure to have the opportunity to talk to you guys. And I think what you forgot to mention, Vivek, is that when we were in Miami, you got a phone call from a physician in New York, which was Dr. Valentin Fuster. And you asked me, there's this guy calling me, this Fuster guy. Do you know him by any chance? And I said, you gotta be kidding me, right? So go there and talk to the man. So this is the first step to move to New York. Back to the United States, as we used to say. So I'm gonna try to move just to show you why we are doing what we are doing. And then when we look at the last 40 years of VT, there's certainly different areas, a lot of progress in what we do. When from surgical to the beautiful maps that you see these days. Do you see my mouse, Vivek, or you don't see the mouse on the screen?
No, you must have it on the other screen.
I'm just... You see it now?
Well, no, see, the problem is now you have it on, now we're seeing the presenter view.
What I did wrong here.
You know, you can duplicate. If you duplicate, then it shouldn't be a problem. You won't have the presenter view, but you don't need the presenter view.
Okay, you see it now?
Now we don't see anything. Now you're not sharing. We're going backwards.
What do you have now?
We see the presentation. It's not in presenter mode, but we see the PowerPoint. Now it's in presenter mode. And we see your mouse. You're all good.
Okay, good. So, and then, as I was saying, there are multiple different contributions over the last 40 years. But the question that we still have to answer is if VT ablation improves mortality. And let's try to answer this question in different ways. So you have this old kind of patient here, which we don't see these days. It's a massive LV aneurysm in a patient with multiple episodes of VT and a reduced ejection fraction. So what do you think we are going to do with a patient like this if we treat his VT? Do you think we're going to improve his mortality? That we have no impact on mortality? This is a very important question that we have to answer. So many years ago, like 30 years ago, we had this approach in Brazil, which was a surgical approach that was very interesting because it would not only remove most of the scar by applying this double plicature on the septal wall, but also removing the remaining part of the aneurysm along the anterior wall. And as a result of that, we had a significant improvement in the LV ejection fraction, which is very important, which is something that we don't do with our current approaches. And even though this was done blindly in the OR, the results in terms of VT recurrence were pretty significant. But as you can see here, despite of this, and this is a time when ICDs were not available, we had out of these 50 initial patients, 48 patients were non-inducible after surgery, despite of the need for no MAP during the operation. But there was a significant overall mortality during the follow-up period. So what I'm trying to say is that this is a sick population, despite of no VT, less ischemia, because these patients were revascularized during the procedure, in a much better LV ejection fraction. There was, I think there was a mortality impact here, but as you can see, the overall mortality remains very high. So what if we look at all the things that we know now and the nice maps that we can create, knowing that in the last 25, 30 years, there was a lot less surgery, there was no new antiarrhythmic drugs. But on the other hand, we have much, much better catheters. Our RF lesions are completely different from the day we started. We can control the comorbidities much better than in the past, and the drugs for heart failure are they're much nicer now than in the past. So with all of this, can we improve mortality with VT ablation? It seems that at least when you look at several this most recent meta-analysis, that VT ablation does reduce VT recurrence, reduces the number of ICD therapy, reduces VT storm. It's been shown in every single one of the trials. Here you have the last 9 VT trials, and this is just the last 8 VT trials. But in a very consistent way, it seems not to impact all-cause mortality, and not even quality of life. And we have to ask ourselves why this is happening. Because if we're not improving mortality, we need to understand what exactly we are doing. And I think we are fooling ourselves when we look at these 3 trials and we keep assuming that VT has an impact on mortality. Because these are the last 3 trials survived from Berzuezo, Tangs, and De La Bella. They all came out as positive trials. But when you look at the reason for them to be so-called positive, is because of not mortality benefit. It's something that happens during the composite outcome, composite endpoint, resulting in a positive trial. Even Partita is the most embarrassing one, that we have only 47 patients, and the reason for the trial to be positive is because the deaths that we had in the Partita control group were not related to any arrhythmic events at all. So in my mind, and I think everybody, when we look at these trials, we understand they're positive trials, but not for the reasons that we would like them to be positive. Do you have any questions, Vivek? Any comments? We've got to make this very informal, right?
Well, no, I thought we'd have you go through this and then we'll have lots of questions.
Okay.
Yeah.
And this is important because if VT ablation reduces ICD therapies and ICD shocks and VT storms and ICD shocks increase mortality, how come that we can't see a very clear mortality benefit after VT ablation? And I think that when we look at the data that we have out there, we need to look at this in a completely different way. And this is the discussion that I always have with Thorndike time. When you look at this nice paper showing the like 3,000 patients had with recurrence and no recurrence, there is an assumption here that whatever you do, if you have VT recurrence, the patients are going to die more, and I think that's correct. But what's very puzzling in this figure is this incredibly early separation. This is not biologically plausible. When you see a separation immediately after a procedure, what you have to ask ourselves is if the procedure itself, it's resulting in, is the main reason for the separation here. And as you know, we'll talk a little bit more about this, most likely in these VT recurrences, the kind of procedure that we had here, we can't prove that looking at the data, but I think there were a lot more. Typically, these procedures are more complicated than the ones that you have no VT inducible at the end and early during the procedure. So the point that I would like to make is that this very early separation here, when we look at other trials, we always say, well, the groups are very different, or the procedure itself is the reason for the difference in outcome. So if that works for other parts of cardiology, it should be the same thing for AP. And it's interesting because when we look at the ejection fraction, that's exactly the same thing. As you can see here, in patients with a high ejection fraction, there is no separation. But in those with a poor ejection fraction, the separation happens immediately after the procedure. And you know, we all know that what happens during these cases, right? If those patients have a low ejection fraction, the procedure itself, and every single time you try to induce a VT, there was a significant reduction on the overall hemodynamic status of that patient, which never returns back to baseline. And this is potentially what's happening here. So we have a patient in heart failure, and during the procedure, what we do, apart from ablating, is to put him in a very severe stage of heart failure decompensation. That cannot be good for him. And in my mind, it doesn't matter how we look at this. Every single time we try to induce, which is a very important tool because sometimes we need to understand the circuit a little bit better. And there are many patients in whom the only option you have is to map during VT. But every single time you do that and you cause hemodynamic decompensation, you may have an impact on short and long-term mortality for those patients. We just wrote this review, came out this week, and trying to show the point here. And as you can see here, whatever we do will always have, in terms of hemodynamic decompensation, will have an impact because will cause AKI or because it's going to have an impact on early or late mortality. So if that's the case, if VT induction and VT recurrence may have a similar impact in longer-term mortality, what's the best in general? Conceptually, the best ablation strategy for us to make those patients non-inducible? It would be great if we could do that and result in no recurrence if we didn't have to induce, so the patient would benefit from the procedure without all the potential effects that you have there. The worst part is probably what we are doing most of the time, which is to start the procedure trying to induce. And I remember in the old days, very proud EPs presented at HRS, a patient who had 12 VTs induced at the beginning of the case. And at the end of the presentation, none of the VTs were inducible. I guess for many different reasons, not necessarily because of ablation. And this has been the strategy. I mean, Vivek and I, we were using this induction first. We had used that for many, many years. But if you think critically about that, I think this is the last thing. If needed, it's the last thing that we should do. Why should we start a procedure putting the patient in his worst possible clinical scenario during his heart failure problem? That's why we are trying to understand if we can have no recurrences with no induction during the initial procedure. For us to do that, we would have to characterize the substrate in different ways. And there are different options here, but I would like to discuss and focus on these three different options here. In terms of mapping, we can use voltage or activation map, but we can also have image incorporated to our mapping systems to understand the substrate. The problem with voltage and activation map is that they're completely different from catheter design and the size of electrodes and the wavefront direction. That doesn't happen with imaging. So how can we negotiate with these three potential options here to define our best ablation strategy? So I was surprised when I went to UPenn to give a talk on VT, and I said that we only use multi-electrode catheters to define the substrate for voltage and activation map. I was surprised because some of the attendings said, well, we're still using point by point to define the substrate there. And I got to tell you, point by point it cannot be used anymore for you to define activation or voltage. It's almost like it's a blind map compared to what you can see when you use these nice multi-electrode new catheters there. The first thing that we are all trying to do, of course, is to define scar and play sometimes with the definition of scar if you can see channels of high voltage inside the substrate. But this is just an example that I'd like to share with you. The main advantage when you're using voltage map is because, it's pretty easy to do that. And you can, during your map, you can also see lava, you can see late potentials, you can see fragmented potentials there. And you can burn them all. And using a probabilistic result, it could be good for some of the patients, especially those with a small substrate. But look at this one here, how interesting this is. So I'm moving the catheter from different locations and change the wavefront before moving the catheter to the next location there. And as you can see, not only your voltage map here doing RV and CS spacing It's completely different from each other, not only the voltage, but also the activation map. When we are using here RV pacing, you can see an area that it stops here, loops around, and comes back to this region. And that feature is gone if you're just looking CS spacing through the normal conduction system. This is just to stress the point that, again, voltage itself and activation are important, but completely different on the wave front direction. And this is the lesion set that we had to apply for this particular patient. Again, we will use a different criteria to define the area of activation, the area of the important target there. And it was easier for us to do that doing RV pacing. We couldn't see anything interesting during normal CS pacing there. So when the omnipole technology came, we said, okay, people keep saying that, and this is correct, that the omnipole will give you the best voltage possible. And that seems to be correct for a given wave front. But this is, again, the same strategy. I'm pacing RV, and without moving the catheter, I'm now pacing CS through the CS lead. So what I'm trying to say is that the points here and here are exactly the same points. This is not a new map. This is exactly the same, the catheter in the same location using two different wave fronts. And yet, it's a dramatic change on the voltage itself. So if you had to define which one you're going to ablate, if you have to simply homogenize the area, I think you're going to try to find the largest one and burn it all here. But you see, I'm just syncing these two images, and the substrate itself, it's very different from RV compared to LV pacing, even with the wave, or even with the omnipole, which again optimizes the voltage for a given wave front, but does not prevent that change from happening, does not change the fact that voltage is still very dependent on the wave front direction. Because of that, we thought that perhaps we could have image integrated to our substrate maps. And this is, we did 50 cases with the in-heart system, and it seems it's a very straightforward strategy. You have your images here, you do a wall thinning, and by doing so, you can see areas of higher, with a thicker wall, where the channels are more likely to leave. And you can simply go there and ablate these things. One thing that we were trying to do is to compare the areas of deceleration with these potential anatomical channels. And as you can see here, this is the paper is going to be published this week. As you can see here, first of all, there's a very large number of channels, which is something that you don't see during activation map. First of all, when you do a nice activation map, you see half of the number of potential channels that you see with imaging there, which by definition, if you just use image, you're going to burn a lot more than if you're using activation. Second, there is a correlation between the decel zones and the areas with the wall thinning, but it's not a very important one. It's not a great one, especially if you have patients without an ischemic cardiomyopathy. And that's why, after our initial experience, we decided not to stop using this and try to focus more on the mapping itself. This is an example where you see the image here with all these potential channels, which can now be actually defined automatically with the new version of the software. But when we overlap our activation map done with a multi-electrode catheter to the image there, the areas that we are going to ablate are just specific points here. And this is even more complicated. The areas are basically out of most of the potential channels seen with the imaging. Which ones are the important ones? Well, I think the mapping itself will give you more relevant information than the simpler anatomical approach that you see here with this. So because of this kind of problem, we decided I think it's helpful if you have it there, but we're not using this as our main strategy. So instead of using these static approaches, which includes definition of voltage and image, which give you like this probabilistic result. The more you burn, the better the results are going to get. We decided to do something different, which is something that we've been trying to do for years. I remember that when I was in New York with Joe from Biosense, we were trying to do this kind of nice activation maps of the scar. But back in the day, we're just using point by point, and it was not an easy thing to do. But now with the new catheters and new mapping systems, I think we can get a much better quality of the map. And the reason for us to do this is because we can try to find areas of discontinuity inside the scar. And we can understand what exactly the role of every single late potential, fragmented, or lava electrogram that you see there. We can define and characterize the presence of deceleration zones and curves and blocks inside the substrate, and by doing so, perhaps we can define our ablation strategy there. This is the dream, right? This is what we're trying to do. This is a map that I got from Rod, and this is during VT. It would be great if we could do the same thing in sinus. And depending on the patient that you're dealing with, if you use the ILM technique, that's pretty much what you can see. This is a patient of mine that I did in Brazil. And as you can see here, all the information in terms of the potential isthmus, the lines of block, the decel zone, that's all in here. Even though this was never induced, I can define my ablation strategy without VT. The question that we have to ask ourselves is how many times we can do this and have this kind of result without VT induction. It's interesting because when we do so, we can actually find the area that is more important within the scar, and most of the time there will be no need for you to ablate, to homogenize the entire scar, and that's important. You will see during this presentation. In this particular patient here, he came to the lab. That's the strategy that we used to map him. We ablated here, we remapped to define the modification, and this patient was discharged the next morning and never had VT induction and remained free of VT for the next 2 years that I followed him. So it's clearly doable. We just need to know if we have enough map resolution to do that. And as I told you, so the maps that we have these days are better than the ones we had before. We are now using this new interesting technology from Biosense, which you can actually validate the lines of block using not only pacing maneuvers. I'll share some of that with you, but more recently we can actually use the vectors orientation to make sure that the lines of block are real. As you can see here, this is what I'm doing, right? I'm basically annotating the first deflection during like a sinus map, and I have my left bundle coming here. The vectors are pointing in that direction, and all of a sudden they turn back. And when I move my catheter to a different potential area with a different line of block here, you see the wave front coming this way, not going there, but actually going around and coming back within the channel. So this is one of the options that we have these days to confirm that these white lines are true lines of block, which is very important. So this is the first case that we decided to use this approach. This is a patient with 2 metallic valves, and we used this Gerbaud approach. This patient was very sick, getting to the hospital on a weekly basis because of bad heart failure and multiple episodes of VT. So what we did here, we went from RA to LA, and we did the map. As a matter of fact, this was the first time I did this Gerbaud approach, and I was surprised at how easy it was to gain access and to map the LV after that. But the strategy that we decided to use here was this. We said, okay, the total activation time for the endocardial LV was 300 milliseconds. And we said, okay, let's apply an extended early mid-slate percentage of 30%, meaning that every single time the system sees 2 points next to each other, less than 2 millimeters from each other, separated for 30% of window of interest, which is 100 milliseconds, we'll define that as block. And when we did the map here, it was interesting because there was a clear line of block here with a gap right in the middle of that line. And that gap had actually a lot of isochronal crowding, suggesting the presence of slow conduction here. This was a potential area. This is the only substrate that we found in this very, very sick heart. And without induction, remember this patient had no hemodynamic support for obvious reasons, right? We decided to ablate here and extend the lesion set in that area inside the line of block. And even though we didn't try to induce during the procedure, the patient died 8 months later, free of VT. So we thought, okay, there is something interesting about this concept of WaDL, which is the way for you to identify the areas, the potential areas of block, and perhaps understand the substrate a little bit better. This is another example. It's a patient with a post-MI septal VT. And when we finish our initial map using the ILAM strategy, you have at least 2 areas with a lot of colors. The problem with ILAM is that you need to it's not easy for you to see what is block, what is deceleration. So when you look at this here, it seems that you have a complete block in this entire area here, because that's what the system tells you. As you can see, this yellow isochrone is so small that it suggests that you actually have a block around this whole scar. But when you apply some rules, if you see the window of interest here, which is around, I'm sorry, you have around 220 milliseconds, and you apply again a extended early mid-slate of 30%, meaning that whenever points are separated by 52 milliseconds or more, remember that the definition of block is 20 milliseconds, you have a completely different visualization and potentially understanding of the problem. What we have now, instead of this, is a potential gap defined by the presence of 2 lines of block which are not present here. This is just slow conduction. It's the wave front that is going in that area and rotating around the end of this line of block. And that's why when you just do the ILAM, you cannot clearly see the difference here. Of course, in the beginning, we had to validate those lines. And we were basically going along the line with multi-electrode catheters to make sure that what we're seeing there was truly block. And this is an interesting one. As you can see here, the wave front is coming here. And when it comes to 910, you have this change on the bipolar polarity, meaning that the wave front here is coming 910. And from there on, it's the opposite. It's 1211. So it's just rotating here very slowly. But what's also interesting is that this part of the substrate, we were recording very interesting late potentials there, which would easily be the target for somebody who is just defining the substrate without looking at the activation. All of these late potentials would become a potential target if you're just ablating electrograms without trying to understand why they're so late, why they're just like that. But what we decided to do, since these late potentials were outside the potential channel, was not to ablate them initially. We decided to close the channel, the potential channel, by connecting, putting lesions here between these 2 lines of block. It's important to mention that this was basically an ablation that we had to ablate only 15% of the total bipolar the low voltage area there. And by closing the gap here, remember this is the initial map. By putting these lesions and closing it here, what happened is a significant modification of the substrate. As you can see here now, this is a remap using exactly the same wave front. But when we do so, the late potentials are gone, even though they were not ablated, because now the wave front, it doesn't need to take this small turn here, and the late potential area is now located in a completely different region. And that's just because we are ablating inside the channel without touching the so-called late potentials. I think this is a nice example. And when we do that, we can also, as we remap using the same wavefront, we can also see that there was a significant change on the total activation time of the chamber that you're mapping. In this particular situation here, there's a change in 40 milliseconds of the total activation time. So we've been trying to define what exactly is the best threshold when you have mapped your chamber. And this is just an example, right? If I have a window of interest of 300 milliseconds here, this is an epicardial map in this post-MI LV patient. It's a redo that we went epi because patient had a recurrence after that. It's clear, right? Depending on the percentage, of course, you're going to have a very long delay between these 2 points, and the size of your line will be longer or shorter. It all depends on how you define what is block, what is not block. So as you can see here, what we typically do, we start with 30% and then we remap the region to see if we can change it to more or less percentage of the window to define what is a line of block. Again, if I look at the island itself, I have this area where I have lots of colors suggesting a decel zone, but this is a beautiful example. I'm not saying that ILM doesn't give you the target that you have to ablate, but it's harder to visualize as compared to what you see when you create these lines of block. Because again, you're going to be able to differentiate what is true block from what is just slow conduction here. And this is the overlap between your ILM and your WaDL map. So what you see here, this is, we are doing the RV pacing, and I have my decapolar catheter sitting in the epicardial space and exploring my potential substrate. So as you can see here, I have a very rapid conduction coming from distal to proximal, as you can see here. When I put my catheter beyond this potential line of block, the activation is still rapid, but goes in the completely different direction. Even though the wave front is coming here, it can't go through. It has to go around and come from there towards the line here. And as I go and I look at the substrate, and I explore these different potential lines of block, I can actually confirm that here there is a massive split between 1 and 2 and 9 and 10 here, and 7 and 8. Between here and here, there's 142 milliseconds, which basically defines that this line of block here, it's real. But look at how interesting this is. Now I'm comparing my VT, which was induced during catheter manipulation, with my WaDL substrate. It's exactly the same circuit here. I mean, not exactly the same circuit, there are a few differences there. First of all, during VT, it seems that there was an extension of this initial line of block, resulting in a longer curve for the wave front to go. And perhaps that's the reason for the VT to be sustained in this particular case. And you can also see here, there is a big gap between the late area of activation and the early one. So this is the definition, which is what we've seen a lot with these WaDLs. When you have this U-shaped kind of WaDLs, it's an indication that there is a 3D circuit here. The VT comes in this direction, stops here, goes endocardially, and then comes back to the epicardial surface, few centimeters away from the line of block. It just confirms that what we are seeing here in sinus, it's also present during VT. And this is, as a joke here, this is what we say, this is when our swaddle, our substrate WaDL equals our twaddle, our tachycardia WaDL. So this, when you have this correlation, but again, it proves that those assumptions here, that these are true lines of block, are correct in most of the cases. And we can use the shape of this substrate to define our lesion set. And this is just to show you again, we're using like the LAT histogram, and as you can see here, we are missing a significant portion of the circuit because you're only mapping epicardially. And the swaddle and twaddle are very similar here, with the exception of the prolongation of this line of block, which again perhaps is facilitating VT to sustain around this potential substrate. And as we had to redefine in our ablation strategy there, by burning only 10% of the area of low voltage, we were able to cause a significant modification of that substrate. This is a different example.
Sorry, Andre, can I interrupt you 1 second?
Sure.
In the previous one, the previous example that you just showed, how would you have deduced this without mapping the circuit, without mapping the VT circuit?
Say that again.
In this particular example, right? If you didn't map the VT, right?
Yeah, so I would have ablated. This is what you're saying, right? I would probably.
This is all you would see.
Yeah, I would burn this whole this area, the common area here. I would, because this seems to be, this is a clear line of block. So this thing is going around and coming here. We have other examples suggesting that when you have this U shape, this is the end of a potential channel that will take the circuit to a different surface. So I would basically focus my ablation around this area here, this potential channel here. So the VT was just used to confirm that what we are seeing here seems to be useful for you to define your lesion set. I'll show you more examples.
Yeah, okay.
So this is one of them. So this is a post-MI that we're mapping here. And again, my window of interest is 200 milliseconds. When I put 30%, it's gonna, every single time, every single Y dot here means a separation of at least 60 milliseconds in points that are 2 millimeters apart. And this is beautiful because I'm using the Dishlu maneuver here. When I pace in this area, I have this QRS configuration, and I just paced 1 millimeter in the other direction, and there was an inversion of the QRS polarity with a significant change on the spike to QRS duration. So the only way for you to have this kind of behavior is if this is a true channel here. And again, Vivek, if I induce VT, I guess the VT will come through the channel. But I have now enough information to define my lesion set without VT induction, as you can see here, right? I think it's a very nice demonstration of that. The closer I get to the exit, my QRS morphology keeps changing a little bit because my spike to QRS is also changing. But when I go deeper inside the channel, my QRS morphology is exactly the same. It's just the spike to QRS that keeps changing. And even from here, from 70 to 150, it's exactly the same QRS morphology. The only way for this to happen is if you are pacing an area that with protected isthmus there. Otherwise, the QRS would have to be different. But look at how interesting this is. This is my area of low voltage. And when I take my image, my potential anatomical channel, it's actually perpendicular to my anatomical channel. So if I had to use my image only, I would probably have ablated more around here and perhaps here. I'm not sure if I would had a chance to ablate just deep inside this channel. Potentially, I would have ablated, if I ablate and expand my lesion set around here, perhaps I would have ablated enough. But it only shows you that there are many examples where your anatomical channel does not align with your EP channel, so-called EP channel there. That's why we're not using that most of the time. This is another example, Vivek, perhaps to answer your question. And so if this is the substrate that we have there, now I needed to validate that I have 1, 2 U-shaped channel, 3, 4 with multiple possible exits there. So is this real or this is just imagination? Again, I put my duodecapolar, my decapolar there, and as you can see here, doing RV pace, and the wave front comes here and then goes around. There's an inversion here with a massive split between 3-4 and 5-6, suggesting that it's got to be blocked right, 130 milliseconds. And then when I pace there, what basically happens is, again, it's a big change on the wavefront, in the direction of the wavefront. So if I have my initial electrogram distal inside this U-shaped channel, and I burn the entrance of the channel, and I remap, I was actually able to eliminate the point here without burning there, suggesting that's correct. So this is a channel, 2 areas of protected, it's a protected isthmus. I was able to close the entrance of the isthmus, and by doing so, eliminate a signal that was deep inside that potential channel. And then there are different demonstrations in this particular situation here, where the 2 wavefronts will collide just exactly at this point. There is no conduction through here. This is a line of block, and the conduction will block on the other side of that line. So these are different maneuvers, Vivek, that we're using to make sure these lines of block, it's like confirming that this is a truly potential substrate there. And when we ablate, we chose to ablate this thing, and we remap shown with exactly the same wavefront. There was a significant reduction of almost 100 milliseconds in the total activation time, which is 35% reduction on the chamber activation side, despite of the fact that we had to ablate just a small portion of this area of slow conduction. This is a Chagas patient. It's a very sick guy. I did this one with an impella. Despite of the impella, we decided not to induce because of his clinical situation, and he did okay for the next several months after ablation. So again, it shows you that even if you have a complex substrate with multiple potential channels, you can still ablate there. Again, just in order to validate the concept, this is a beautiful case. This is an ARVC patient, and as you can see, this is the voltage map down here. When we did the endocardial map, it was bizarre, right? We have an island of isolation here. Is that even possible? I never heard about this. So basically the activation comes this way and does not penetrate, cannot penetrate in this small portion here. Is this imagination or this is real? Well, when we look at the electrograms, this is what's actually happening there. The wavefront comes in. There is, in this particular region, there are only far field endocardially, epicardial far field here. And then when we see the near field, it's very late. So this seems again to be the case. And when you put the vectors there, the vectors are pointing from the center of the area outside, suggesting that again, even this bizarre shape of the line of block can be real, and this area is being completely separated from the substrate. This is when if you had a VT here, it would have to be a 3D VT, which happens to be the case in many of these patients with ARVC. Again, suggesting that if you validate the line, it can be useful in defining your strategy. Of course, and this is something that is, I mean, it's pretty basic, but people keep saying this and I don't understand why. This is a different patient, and this is LV. We are pacing the LV. I think this one we always try to find the CS branch so we can compare at least 2 different wavefronts. And the substrate that you see is completely different because, of course, depending on how the wavefront gets to the line, you're going to be able to see the line or not. But the fact that the true line of block can be seen here and not here, it doesn't make it this one functional. It's more fixed than ever. It's the same concept for a CTI line. You put the line, sinus, you can't see anything, you paste the CS, the line is there. It's not a functional line because you cannot see it during sinus. It's just because it's going to be able for you to characterize the substrate depending on how the wavefront approaches that area there. That's what we would call concealed line of block. It's not that it's not there, it's just you're not able to see that with a specific wavefront. And when we look at our data, we were able to find this, at least so far, there's 5 different potential channels, as you can see here. You can see gaps with a single line, you can see these isolated areas, you can see wide channels, you can see narrow channels, you can be a combination of all of this, including these 3D shaped ones, which are most of the time a potential indication of a 3D circuit there. meaning that the VT is coming here, but it's not going to die here. Actually, it's going to go here and go to the subendocardial, a different layer of the substrate. So as a quick summary, and this is the paper that we're preparing now. So in the beginning, we did some inductions, and we were trying to compare the distance and how to validate these waddles using VT. Basically, we define it as critical sites using these 4 different criteria here in the population of 50 patients. That's typically the kind of guys that you see during ablation. 30% of them had a previous ablation there. And first of all, when we look at this, it's important to say that during LV pacing, this is when we saw the least number of waddles. And the difference in terms of using a threshold, it seems like 30%. It's a nice beginning. It's a nice start, and you can always move from there. It's also nice to see that this 30% works for both, for epi and for endo. Most of the time, depending on the cardiomyopathy, the wave front, and what surface we are mapping, this is the distances that we see between the critical VT site and the closest waddle. And it's always within 15 milliseconds. It varies a little bit with this, but the numbers are too small. But it's just to make the point that these things, when you induce, and of course there's always a little shift on the map, they're typically very close to what we see. So the distance here, I think it's an important topic. And this is our basically our initial data here, showing that we had to ablate, for the results that I'm going to show in a second, around 20% of the bipolar percentage area. And when we do so, as a group at least, there was a reduction of around 40 milliseconds of the total activation time of that window. Basically 30 seconds reduction in the total activation time there, which could be a way for you to define a different criteria for you to define the result of your substrate modification. And this is one of my very last slides. So just to show you that when we look at the data here, comparing patients, using basically here now, it's basically most of these patients were not induced on purpose. Some of these patients had VT during catheter manipulation, but these are the results that we have there. And what's very important is that even though the ejection fraction of these patients were 30% or so, around 30%, VT recurrence in that population did not increase mortality. And most of these patients, especially those who came from home from an elective procedure, these patients were discharged the same day. I think this is important because, of course, we measure the LA pressure at the end of the procedure, and therefore it's not a significant change. If the patient had no induction, if the modification was okay, so we feel comfortable sending the patient the same day. Of course, these patients, the ones who go home the same day, did not have an epicardial approach there. Even though the group mortality, it's exactly the same as the one presented by the IVTCC data, the first figure that I showed you, in this particular subgroup of patients, the ejection fraction is a little bit higher, but VT recurrence did not impact mortality, which is the least we can do when we bring these sick patients to the lab. Even if you cannot succeed during your procedure, don't make the situation worse for that kind of patients. So this is my last slide. Again, this concept of wavefront discontinuity is not new. I just think it's a better representation of your ILAM maps. And it can identify, this can be done automatically. It's fast. Most of the time, the waddles using a good percentage, they represent a line of block and or a very significant delay, which can help you define the strategy for your substrate modification without the need for VT induction. And that, Vivek, is what I had to present. Thank you for your time, and I'm happy if you have any questions there.
Well, that's fantastic, Andre. Thanks for this very detailed presentation. I mean, I have a number of questions, but I don't want to hog up the time. So if people have questions, either just send it to me in the chat box or please feel free to ask the question. While people are thinking, let me just ask you a couple questions. So what do you think? You never answered, I think, your first question. Does VT ablation affect mortality?
I think VT ablation.
Sorry, let me rephrase the question. Can VT ablation affect mortality?
I think it can. It would make sense because it reduces VT, the number of VTs, reduces VT storm, it reduces VT ICD shocks. The problem is that what we are doing to achieve that goal, it's increasing VT. It kind of compensates for all the hemodynamic decompensation caused during our VT ablation compensates the mortality benefit for your reduction in the ICD shocks. I mean, that's the working hypothesis. I can't prove that. So I think VT ablation could improve mortality, but we gotta change the way we ablate in these people, because if we keep inducing, nothing's going to happen. Listen, when you look at the data, at least Arash and I, we published this, when you're using Impella in a Medicare setting, right? The VT recurrence was exactly the same. The mortality was not in those patients who were mapped using Impella, suggesting that if you simply put an Impella in, by the hemodynamic improvement of that, this can actually change the overall mortality rate in terms of heart failure, even though it's not touching VT, the VT recurrence rate.
So are you doing any VT inductions now for your cases?
Only when of course I didn't cover it here, there are many patients in whom you see no clear WaDLs, no clear substrate. So you have no option. There is no decel zone, there is nothing there. And then the only thing you have to do is to induce, especially for those septal ones.
So to your earlier point, are you then adding hemodynamic support to offset that balance again?
No, I only, if I bring a patient, Mark, and I always put, I have done I think I have 140 cases in the last 3 years here. So I've done Impella in 12 of them, including a 5.5 in a very sick patient there. So I only put Impella to support the clinical condition, but not for induction. But if I have the first case, I have the first ablation session, I don't see anything. I try to induce, the patient does not tolerate. As you know, rescue Impella is never a good idea. So I just stop the procedure, and if the patient has a recurrence, I'll bring him back, and then I'll have him with an Impella before the redo. But I'm not using Impella during the first case to support my induction strategy if I have to induce.
Andre, just a comment and a question. I mean, I understand your point about the mortality point. And I certainly can appreciate why acute decompensation will affect short, maybe midterm mortality. I'm not sure how it affects long-term mortality. But I would just present this, though. I don't think it's necessarily VT that kills people. VT certainly can kill people, but it's also all of the stuff that goes with VT when you don't ablate, right? It's the antiarrhythmics that you give that also can cause a demise. I mean, we know that amio worsens mortality, worsens non-sudden death, but it's offset by the benefit of reduction of VT. I mean, I think that's pretty well accepted. So I guess the point I'm trying to make is it's not like AFib and heart failure, where it probably is the burden of AFib that causes further decompensation in heart failure, right? With VT, the burden of VT is usually very, very low when you think of the absolute time perspective. So I'm actually not as negative as you seem to be about Partita. I mean, Partita was a victim of its own success. The reality is many of the deaths in the control group, I don't think it's necessarily, yes, they didn't die of VT, but they died of things that may have been potentiated by other management. So that's my only point. But my question is this, actually, one of our fellows, Chi, asked the question, How exactly, just a very technical question, how exactly do you set up your window of interest?
Well, the interest is from the beginning of the QRS to your very late electrogram. Of course, the window will vary as you go mapping, right? You don't know yet, so you put whatever you want, beginning of the QRS, peak of the QRS, and then you give 200, 250 milliseconds. If you have an electrogram that is longer than that, you just extend your window with the dynamic window now. And now we're basically using the LAM software, which does exactly what Navex does. Most of our cases are now done with Cardo. It goes from right to left, finds the last electrogram, and looks for a unipolar that corresponds with the peak voltage inside the late potential. And the window of interest is just the latest potential that you find there. What's interesting, Vivek, I'm using the Optrail 36, which is great for you to maneuver inside the LV. But I'm not sure if it's because it's smaller than the 48. It creates a lot of noise. Sometimes you have the impression that is actually a late potential. You have to sit there for 5-10 beats to make sure that it's consistent or not, because it's just bouncing in a way that it looks like a very sharp, nice late potential. So I think it's easier for you to maneuver the 36 in the chamber, but the 48 is better in that specific regard.
One other question, intramyocardial fat, there's been a lot of work published recently when you're talking about substrate, that may actually be the missing link if there is a single missing link to defining the substrate. What do you think of that?
I think it's a great concept, and we are trying to. The reason for us to move from CT now to Berezo with MRIs, because we're trying to do the same correlation that we're trying to establish with wall thinning, with the presence of fat there. At the end of the day, fat or scar, they will both give you a line of block. In terms of substrate, it doesn't matter if you're dealing with scar or fat. I think the mapping strategy is still the same. Fat would be great. It could be more specific in terms of defining the channel, because it's easy to see that with our image modalities there and just register that to the map. So we are trying to understand if there is a role for that. Again, not for VT induction, but for substrate modification without the need for induction. But I don't have an answer for that. I just think it's a very, very nice concept.
Andre or Vivek, can you just expand on that comment of why you think fat is the missing link, just for us who are not?
Well, so there's been some really nice work by Natalia Trainor and from the Penn group. Oh my God, I'm blanking on his name.
Orion.
I'm sorry?
Excellent.
You're blanking on his name too, but you know what I'm talking about.
I talked to him last week.
Yeah, really nice work showing that when you look at intramyocardial fat on CT or MR for that matter, that seems to be, let's say, correlative to important sites, VT targets. It seems to be consistent with slowing of conduction in those regions. So it seems to be, let's say, a little more specific than looking at thinning of tissue or putative channels just based on geometry.
Because they say, Mark, that the impedance mismatch is so important between scar fat and normal tissue that fat will allow for a high concentration of current within the channel, which will make that channel propagate conduction. This source and sink mismatch will be minimized by the presence of a fat that allows for this concentration of current in a given channel, because you have lots of channels, right? And why ones are more important than others. So potentially because fat will give the channel that electrical property to allow the channel to conduct in a more consistent way. That's why it will become an important channel for that.
So is fat a contributor to the VT, or is it a result of local injury or scar? Is it just a marker, or is it a cause?
No, VT would be a cause. It creates in similar scars. Those who have more fat are supposed to be more arrhythmogenic, and the explanation is what we are trying to say. It just amplifies the role of the specific fat by allowing a more current density to run through that fat, which would make that channel more important than the neighbor channel.
Just one last question or comment, Andre. It seems like as our tools get better, let's say 2 years from now, we're going to have better ablation tools, right? Large focal catheters, RF, PF, who knows? But it's going to get better for sure. What'll be interesting is what happens, right? You'll have the Natali approach of letting off a neutron bomb in that location, and you'll have other approaches, WaDL or perhaps other ones, of trying to sort of say no, focus on a critical area. And I guess what'll matter, I suppose, is how do you get to the end result quickest, least heart failure, and I guess also least technical complexity, right? Do you think I'm thinking about it right, or you have any other thoughts on that?
Well, I think you're absolutely right, and the reason for us to try to minimize the need for ablation is because of PFA. I want to be as precise as possible. Of course, if you're dealing with a small substrate, who cares, right? Voltage should be enough, we just go blast the whole thing. But if you have those that are just showing now, I mean, it takes a lot of time for you to make redder in an area of low voltage. And I think we need to understand these things a little bit better before we can simply recommend ablation of low voltage area. Clearly, a scar does not mean VT. So you have 100 patients with an identical scar and only 3 will have a VT. So there is something special in those 3 scars that will make them arrhythmogenic. I think our job as an EP is to find those areas and deliver the very best, most powerful potential lesion there without causing the problems that you're just referring to. That's why I think we have to be more specific. And to be honest with you, it doesn't take long. I mean, mapping voltage or mapping activation, it's exactly the same thing. It's just a different look at the same problem.
So you need to repeat must with WaDL.
We will.
Well, look, this is fantastic presentation, Andre. Great discussion. Thanks so much for joining us. And I think our honorarium is a Starbucks ticket for coffee. So
that's all I need. That's all I need. Next time I want to go there and visit you guys live. I'll try.
Absolutely.
Hey guys, thank you very much, and was an honor for me to present for you. Thank you.
Bye, Andre.